So this is a simple question. Nikolsky's sign is positive in pemphigus, dermatitis herpetiformis, bullous pemphigoid, or rubella. So the answer, most commonly, Nikolsky sign is positive in pemphigus. The other diseases where it is positive is Stevens-Johnson syndrome or toxic epidermal necrolysis and staphylococcal scalded skin syndrome. Nikolsky, again to recall, is to distinguish between intraepidermal blistering disorders where the epidermis easily slides off, separates from the dermis, and subepidermal disorders where Nikolsky sign will be negative, like bullous pemphigoid. So now we're coming to subepidermal blistering disorders. These are classically tense bulla, and these will classically heal with some amount of scarring, okay, because it has crossed the base membrane zone. And yeah, so bullous pemphigoid, as you can see here, there's a tense bulla in the first picture overlying an erythematous plaque. In the second one, you'll see some hemorrhagic blisters and bullae, which can also occur commonly in bullous pemphigoid. So classically subepidermal blisters, that means tense blisters and bullae. BP occurs usually in older patients, so classically above 60 years of age. They will commonly have comorbidities as well. It does not involve mucosa typically, so you will not have oral or ocular lesions in bullous pemphigoid. However, there is a less common one variant. This is called cicatricial pemphigoid or scarring pemphigoid, which will involve the oral and the ocular mucosa. So that can cause damage to the mucosa, as the name suggests, scarring pemphigoid. Okay, BP involves the trunk usually, so the abdomen, the flexors, the forearms, and the inner thighs. On histology, so histopath will show a subepidermal blister, and you will have a lot of eosinophils in the blister cavity. This also suggests that the disease is actually, it's quite itchy in the initial stages. So sometimes in initial stages of BP, you will have itchy erythematous plaques, and then it evolves to form these tense subepidermal blisters. The antigens are important to know. You have BPAG1 and BPAG2, or BP180 and BP230. DIF will show you a linear band. So there's a linear deposition of these antibodies at the basement membrane zone. I'll show you the DIF photos in the next few slides. This is a relatively less severe disease, so it's self-remitting. It lasts 2 to 6 years and it resolves by itself. Epidermolysis bullosa acquisita. This is a subepidermal condition occurring usually in elderly patients, and here you can see blisters on the acral surfaces. These will typically scar. So you have mainly trauma-prone areas of the skin that are involved, so the extensors, elbows, knees, ankles, and buttocks as well. As I said, they heal with scarring because these are subepidermal blisters. The antigen in this disease is type 7 collagen. On histopath, you'll see the subepidermal blister, and there's very little inflammation in this. A DIF will show a linear band at the basement membrane zone. This is not very commonly asked in EBA. Okay, this is a genetic disorder. So here we have dermatitis herpetiformis. These lesions are not very clear. They're basically excoriated papules. So you'll have some sort of papulovesicles which have been excoriated, and they occur on classical sites. So dermatitis herpetiformis associated with HLA-B8. Onset of disease is usually 20 to 40 years of age, and they are extremely itchy. So intensely pruritic and chronic grouped papules or vesicles in a herpetiform distribution. That means grouped, right? The classical sites are the extensor surfaces, so buttocks are common, posterior hairline, and the nuchal, that means the back of the neck. Those areas, as well as the shoulders, are commonly involved. Oral lesions are very rare, not really occur. And dermatitis herpetiformis is associated with a gluten-sensitive enteropathy as well, and several other autoimmune conditions like thyroiditis. It's also known to improve when the patient adapts a gluten-free diet. That's important to know. So there are some antigens in dermatitis herpetiformis. You have IgA antibodies to gliadin, which is a component of the wheat protein. This is why when you have a gluten-free diet, these antibodies are not formed so much and the disease resolves. IgA anti-endomysial antibodies, also known as anti-TTG, tissue transglutaminase. These are just important names you have to remember associated with these disease. Histopath will show you subepidermal blisters, and you will have neutrophilic microabscesses, that means small collections within the dermal papillae. DIF will show you granular deposits in the dermal papillae, okay, in the lesional and non-lesional skin. Dermatitis herpetiformis can lead to an increased incidence of GI lymphoma later on in life. So diagnostic procedures for vesicobullous conditions. The first test that you will do is a Nikolsky test, that is the bedside test, right, to determine whether intraepidermal or subepidermal. The next step you will do is you can deroof the blister and do a zinc smear from the base of the blister to check for acantholytic cells or any specific types of cells. Biopsy is then the next step. So you have two types of biopsies you would do in a vesicobullous condition, usually to detect autoimmune vesicobullous conditions. The first is the regular histopath for HNE, which you will take from the edge of the blister. So that's where you will be able to clearly see the split in the blister level. And another another biopsy that you will do is for direct immunofluorescence, and this is typically done from perilesional skin, that means just outside the blister. This biopsy is put into a special medium called Michel's medium, okay, and stained with fluorescent dyes. So that is for immunofluorescence. Okay, this chart is quite important to know. It tells you the list of the diseases and the antigens accordingly. So pemphigus vulgaris, most important antigens are desmoglein 3, which is more common, and desmoglein 1. Pemphigus foliaceus is desmoglein 1, which is present more in the superficial epidermis, right? Desmoglein 3 is usually present just suprabasal. Bullous pemphigoid has BPAG 1 and 2, also known as BP 180 and 230. Epidermolysis bullosa acquisita has type 7 collagen, and dermatitis herpetiformis has tissue transglutaminase. The others are not so common, so you don't have to know these. Okay, a question. A middle-aged lady has flaccid bullae on skin and oral erosions. Histopath shows intraepidermal acantholytic blisters. So what is the most likely diagnosis? Pemphigus vulgaris, paraneoplastic pemphigus, bullous pemphigoid, or dermatitis herpetiformis. So this is quite straightforward. Flaccid bullae, that means intraepidermal, oral lesions suggestive of pemphigus vulgaris, could also be paraneoplastic pemphigus. Histopath confirming intraepidermal blister. So the answer is pemphigus vulgaris. Paraneoplastic pemphigus would usually occur in an older patient, and there would be something in the history to suggest they also have a cancer, malignancy. Bullous pemphigoid is a subepidermal blister, so these are tense blisters. Dermatitis herpetiformis, again, these lesions do not suggest dermatitis herpetiformis. The antigen defect in pemphigus vulgaris is desmoglein 1 or 3, desmocolin 3 or 2. So as I said, most commonly is desmoglein 3, followed by desmoglein 1 in pemphigus vulgaris. Intraepidermal blisters are seen in all of the following except pemphigus foliaceus, pemphigus vulgaris, paraneoplastic pemphigus, and bullous pemphigoid. So options A, B, and C are all intraepidermal. So this is straightforward. Bullous pemphigoid, the subepidermal blister, is the answer. Disease of dermoepidermal junction is pemphigus vulgaris, atopic dermatitis, bullous pemphigoid, or staphylococcal scalded skin syndrome. So the answer here is bullous pemphigoid. Pemphigus vulgaris is an intraepidermal blister. Atopic dermatitis is not a blistering condition, and staphylococcal scalded syndrome is also intraepidermal blistering condition. A fishnet pattern is seen in pemphigus vulgaris, Darier's disease, bullous pemphigoid, or dermatitis herpetiformis. So they're talking about direct immunofluorescence, showing a fishnet pattern. The answer here is pemphigus vulgaris, and I'll explain direct immunofluorescence now in autoimmune vesicobullous conditions. Here is pemphigus foliaceus. So on the left, you see the histopath where there's very superficial exfoliation almost at the, just a subcorneal layer, okay, the stratum corneum. The lower layers of epidermis are intact. So on the right, you will see a very superficial fishnet pattern in the epidermis. That is antibodies which are lining the epidermal cells all around, so it forms a net pattern. This is pemphigus vulgaris. So on the left, the histopath shows a deeper involvement in the epidermis. It's the lower epidermis. That's in the spinous layer. So you see acantholysis there. You can see a blister cavity over there. And on the right, you see the fishnet pattern, which involves most of the epidermis. This is bullous pemphigoid. So in the left photo here, you see a subepidermal blister. Okay, a subepidermal blister is so because, as you can see on the roof of the blister, the entire basement membrane zone has been lifted up, and so there is no tombstone appearance, okay, in the base of the blister. It's just the dermis over here. Whereas in pemphigus vulgaris, if you go to the previous slide, you will see a tombstone appearance of the keratinocytes lining the basal layer in the base of the blister. So in bullous pemphigoid here, there can, if you look closely, you can see pinkish dots, though those are eosinophils in the blister cavity, as well as some serum. And in the right side, you see in DIF, there is a linear deposition of antibodies that is at the basement membrane zone. So a few more questions. Tens bullae are seen in pemphigus vulgaris, pemphigus foliaceus, bullous pemphigoid, or pemphigus vegetans. Pemphigus vulgaris, flaccid blister, pemphigus foliaceus, crusting, bullous pemphigoid, tense blister, and pemphigus vegetans, vegetative lesions. So that's an easy one. Pemphigus vulgaris Zank smear shows acantholytic cells, fibroblasts, macrophages, or neutrophils. This is a straightforward question. Intraepidermal intercellular IgG deposition is seen in pemphigus vulgaris, bullous pemphigoid, herpes genitalis, or porphyria. So intraepidermal antibody deposition is seen in pemphigus vulgaris, causing a fishnet pattern on direct immunofluorescence. Bullous pemphigoid, to recall, causes a linear deposition of antibodies, so you'll have a line at the basement membrane zone. Skin disease not showing direct immunofluorescence, Darier's disease, Haley disease, cicatricial pemphigoid, or dermatitis herpetiformis. So the answer here is Darier's disease or keratosis follicularis. The other three conditions are bullous disorders, in which you will have some the antibodies seen on direct immunofluorescence. Toxic epidermal necrolysis involves body surface area of less than 10%, 10 to 20%, 20 to 30%, or greater than 30%. The answer is greater than 30%. So TEN or SJS is basically a drug-induced reaction in which there is extensive blistering of the whole body, as I said, and this causes just erosion of large areas of skin. And the difference between SJS and TEN, it is called Stevens-Johnson syndrome typically when you have less than 10% of body surface involvement, and when the same disease extends to more than 30% of body surface area, it's called toxic epidermal necrolysis. This basically indicates the severity and the mortality risk as well. What is not true about erythema multiforme? Associated with herpes simplex, involves distal parts of extremities, vesicles are seen, target lesions are seen. So the answer here is vesicles are seen. Erythema, all the other points are true of erythema multiforme. So This is classic lesions of erythema multiforme seen on the palms. These are called target lesions. So you have a central dot of necrosis surrounded by erythema, and then this pale zone, as you can see, which can blister later on. But there are no vesicles seen in erythema multiforme. So EM, erythema multiforme, can be associated with viral infection, herpes simplex, or after intake of drugs. So it is also a drug reaction. Most common drugs causing erythema multiforme, as well as Stevens-Johnson and toxic epidermal necrolysis, are NSAIDs, sulfonamides, penicillamine. Other drugs are also phenytoin, carbamazepine, antiretroviral drugs as well. So you have erythematous target lesions, typically on acral skin. They may also have shallow oral ulceration, so there's oral involvement as well as crusted bleeding lips, and eye involvement also. So Stevens-Johnson syndrome is a severe form of erythema multiforme, which involves the mucosa. And if you do histopath, you would see subepithelial edema and a mixed inflammatory infiltrate. So there is some sort of a blister formation. It's not, it's subepidermal. Here you can see lesions of erythema multiforme on the proximal parts of the limb. So these are target lesions. If you look closely, they are coalescing. A 30-year-old male had severely itchy papillovesicular lesions on extremities, knees, elbows, and buttocks for 1 year. DIF staining of the lesion showed IgA deposition at dermal papillary tips. So the most probable diagnosis is pemphigus vulgaris, bullous pemphigoid, dermatitis herpetiformis, or nummular eczema. So the answer here is quite straightforward. It's dermatitis herpetiformis. A gluten-free diet is beneficial in psoriasis, exfoliative dermatitis, dermatitis herpetiformis, or pemphigoid. Again, the answer here is dermatitis herpetiformis. In psoriasis, the dietary restrictions are basically avoid alcohol and smoking because both exacerbate psoriasis. Also, less fatty diet would benefit psoriasis because psoriasis is associated with metabolic syndromes. Exfoliative dermatitis in such a condition, which is basically exfoliation of skin involving 90% of your body, this results in a lot of loss of protein, right, because of the keratinocytes being lost. So you would need a high protein diet in such a case. In pemphigoid and pemphigus vulgaris, there may be dietary restrictions that involve garlic and onion, but this is not so important to know. So here you have Haley disease. This is the axilla of a patient in which you can see these plaques which are sort of macerated, right? They're wet looking, moist looking, and they've got cuts or raw surfaces on them. You'll see this bilaterally, okay? Both axilla will be affected. You may have them also in the inframammary areas or the groin. So Haley affects the flexors. And if you take a biopsy from the lesion, you will get a dilapidated brick wall appearance. This is important to know. So Haley is a disorder with autosomal dominant inheritance. It is due to the mutation in the ATP2C1 gene. This encodes the calcium ATPase enzyme. So this causes loss of cellular adhesion in the stratum spinosum, thereby causing acantholysis. The lesions occur usually in the second or third decade of life, and they're usually in the fold, so the intertriginous areas and the lateral parts of the neck. The flaccid vesicles are seen on erythematous or normal skin, and these easily rupture, causing macerated or crusted erosion. The histopath shows a dilapidated brick wall appearance of the lower epidermis, as you can see here. That's because of the irregular acantholysis. A patient presents with persistent, painful oral lesions. Could it be pemphigus vulgaris, dermatitis herpetiformis, epidermolysis bullosa, or bullous pemphigoid? So out of these, dermatitis herpetiformis does not have oral erosions. Painful persistent oral erosions Bullous pemphigoid also does not typically have oral involvement, and epidermolysis bullosa, they haven't specified which one, but we can assume that it's more commonly seen in pemphigus vulgaris, so that is the best answer.